This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of personal care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're exploring the fascinating and indeed complex topic of NATO trauma management on the battlefield. So the differences and disparities in trauma management systems across NATO nations during the Afghanistan conflict, but also amongst many different conflicts, has been brought to light recently as a topic of interest, and we're certainly going to cover that today on the podcast. So, coalition operations in Afghanistan brought together militaries with very different medical doctrines, training and resources, all aimed to deliver life-saving care in challenging environments. The way pre-hospital trauma was approached varied significantly between countries. So from casualty evacuation protocols and triage pathways to interventions like tourniquet use, haemostatic agents and advanced airway management, these differences have real impacts on patient outcomes. So in this episode, we're going to delve into how these systems compared, the challenges of interoperability in multinational operations, but also the lessons learned that have since shaped modern military and pre-hospital trauma care. So our discussions are also going to touch on the practical implications for civilian trauma systems and multinational disaster response. So joining me for this conversation is Anita, Podlasin, who brings extensive experience in military medicine and pre-hospital trauma systems. Together, we're going to unpack what worked, what didn't work, and indeed her empirical research and how these experiences continue to influence trauma care today. Welcome to the podcast, Anita.
Nice to be here. Happy to share my knowledge and experience in that manner.
I wonder if we could just start, Anita, just by setting the scene, and if you could just maybe give us an overview, really, of how trauma management systems were structured across NATO, different NATO nations during the Afghanistan conflict.
So happy that the Afghanistan conflict was under the Article 5 Washington Treaty, which stands that we are, the alliance, stand together to defense our values. And in that terms, we are dealing with medicine in very specific way, but standardized way. And we were based on the medical doctrine, which underlines some most important things to be done to assure that patient will have proper standard of care. So starting from the point of injury, then through different echelons of care, quick evacuation and surgical help as a definitive care. And I think we managed to do it. However, our healthcare system, military healthcare system, were different. So we struggled a lot at the beginning of the conflict, to be honest. We had a lot of issues, starting from the English, starting from the communication, and then through logistics and the medical procedures and the scope of practice. However, the AGP 410, the current doctrine, is evolving, but the standard of care is the same, and it's based on the echelons of care. So it was not easy, but we had the starting point at the beginning of the of this conflict.
So, Anita, in your mind, what really stood out as some of the key operational and or logistical differences between countries when it came to pre-hospital trauma care?
So logistic is everything, and the medical supplies and the medical assets is a part of logistics. So when we're talking about evacuation assets, uh, Poland was based on the ground evacuation, US, UK on the air evacuation, which was quicker, and it was better for the wounded soldiers. So started from that. Different platforms, different backpacks, and medical equipment. So we knew at the point that the CCC guidelines is in the right at the very beginning because it started from 1996, and then it was explored in the Iraqi conflict. However, we still struggling with the chain of supply. So we differ in that manner, definitely. So I think at the beginning it was difficult because even the letters and the all the description of the medical equipment, for example, was in Polish. So for the U.S. soldiers, it was very difficult to have idea what is that kind of medical equipment. However, I think that during the conflict and the closer cooperation on the battlefield, we were able to know each other and to cooperate closely and even share our medical assets. So that was great, and I think that, for example, in our base were two hospitals, Polish and the US, and we had better capabilities in terms of sterilization. So we share that capabilities. So NATO is for pooling and sharing, and it's very valuable that you can fulfill the gap within alliance and have greater impact on the casualties.
As you were saying, Anita, standardization is absolutely key. And to your earlier point, you don't sometimes know there's going to be these roadblocks or indeed single points of failure until you bump up against them. Like you said, just the way medical devices or indeed applications are labeled, and having that standardization. You've spoken to something key, and you were talking about, logistics, which is fundamental. And actually, logistics of casualty evacuation is also fundamental. Could I get you to speak to really how casualty evacuation protocols differ between NATO nations and indeed what impact that had and can have on outcomes?
So to be honest, the ground medevac is always slower. And in terms of fulfilling the golden hour timelines, we should think about when you have air superiority, and that was the case in Afghanistan. Your patient could be faster in the OR, and this is crucial. So I think once again, I underline this, that NATO fulfill the gaps. So I mean, Polish armed forces use the medevac capabilities from the US side, and it was good. And also, there were sometimes the weather condition, for example, that they use our assets. The rule and the standards of medical evacuation was the same: nine-liner, the medevac request, and the scramble, whether it was a ground medevac, whether it was a air medevac. We put patient on board and then just evacuate and strictly to the role one, or maybe from time to time to the to the role two. To explain, role two, it's the brigade level capabilities with the surgical capabilities on site, which is crucial. In terms of trauma and dealing with trauma, time is one condition, and the second is definitive care, which is the surgical capabilities. If you don't have surgical capabilities, you can be great in the medical procedures on the ground and in damage control resuscitation, but still struggle with the definitive care. So in terms of evacuation, we got a great teams, I would say. From time to time, we switch teams. So, for example, one of Polish medic could be a part of the air medevac, and the US soldier could be a ground medevac member team. So it was great as well to share some information, to share some scope of practice. It was different scope of practice, the US scope of practice, the UK scope of practice, and the Eastern European scope of practice is very different. I would not want to say more about that, but it was different.
Yeah, indeed. No, indeed. And that comes with its own challenges because to your point, Anita, when ceilings of care are different, and if there's an advanced intervention like an airway intervention, if that's handed over to a separate team, a NATO team, there's got to be some understanding of that level of intervention. And otherwise, and it's to your point, it becomes battle tested. So there is this standardization. So there's an appropriate and a common ground of standard of care and ceiling of care so that there can be almost a synchronous handing over of the patient to the next level without, like you said, just not necessarily mismanagement, but just this bumpy transition between teams. But could I get you to speak to, so something you've really interestingly articulated there is, just even the basics such as tourniquet usage and hemostatic dressings. One of the pivots we're seeing within NATO now is we're starting to train the basic soldier up to a level whereby it's almost a far more advanced, but it brings forward the standard of care straight to point of wounding. So you're not waiting for a medical team or a rapid response team or quick reaction team to actually get to the patient. You're putting medical capabilities in the hands of frontline soldiers, which is a powerful pivot really, because they're starting to get a semblance of a bundle of care a lot quicker. Could I get you to sort of speak to that?
So we are facing right now, I would say, the critical shift in the military medicine, and we started very good. We were at some point in a in some kind of pink bubble because we have great we had actually great medevac capabilities. And now when we see modern conflict, high intensity, multi-domain conflict, we are struggling with the evacuation timelines. So if we know, based on the EMB, EBM, sorry, that the survivability is based on the timelines and the golden hour, and we cannot fulfill these timelines. So we should challenge non-medical personnel and put the medical care far forward to buy a time for the medical personnel in order to get a proper survivability on the battlefield. It's very difficult. We are constantly discussing among NATO members. It's even the NATO medical committee issued a medical action plan that underline 5 critical challenges in modern conflict, which is low regulations in terms of the scope of practice, and also not only the scope of practice, blood, for example. In World War II, blood was delivered on the battlefield within hundreds of thousands of liters and units. Now we are struggling because we are so strict to the modern law that it's basically in some nations it's impossible to deliver blood far forward. Second is mass casualty events. We are not talking about the coin operation with the counterinsurgency operation that we faced in Afghanistan. We are talking about high intensity, multi-domain conflicts. We are talking about the next challenge is workforce shortage. And we are struggling with the lack of medical capabilities, medical assets on ground. And also not only lack of the medical capabilities, but also the preservation of life of the medical personnel. So you see in Gaza, you see it in Ukrainian conflict that Geneva Convention is not the case anymore, and medical personnel and medical facilities, both civilians and military, are targeted by the enemy. So if we're talking about that, we should focus more how to face the challenge and what to do in terms of life preservation, both civilian and medical military personnel. Logistics, as you said, we are living in the very splitted world, multipolar world. The competition in terms of trades, in terms of medical products gaining, based on different produce capabilities, it's all challenge because when something happened, the competition in terms of medical capabilities. So, as you can see, there are a lot of challenges in medical aspect of the conflicts, and also, I will be honest. From time to time, we forgot about the medicine, military medicine as a domain, because all in all, there will be some the high volume of casualties, and we should think about that. And I know that NATO is talking about that, and each nation's I think try to figure things out how to deal with such challenges.
Yeah, indeed. No, indeed. And like you said, it's multifactorial in the stressors. One of the points you articulate there, Anita, very, very well is that, like you said, with the scope of practice deviating or indeed challenging and trying to align that, it really comes back to differences in training. Has there been any efforts really to really align training so there is almost mandates or indeed dictates scope of practice, because there's starting to become a standardization of training within the medical domain between NATO countries?
So definitely there are some standardization documents in terms of training, and we know it, and we have it on the table. However, as I said, we are now facing the main challenge and the main shift of military medicine. So we cannot no longer see that only, for example, only medical professionals can do procedure A or procedure B, because in terms of high casualty volumes, there will probably there's gonna be no medical personnel on site in the CCP. So what we can do, we can create training, advanced training for non-medical personnel in order to buy some time for the patients and maybe to fulfill the gap of the quick evacuation, hopefully. And of course, NATO is saying, and I think it's crucial, that the timelines should be fulfilled, because we should, based on the golden hour. The golden hours give us opportunity, not us, but the patients opportunity in the proper care, that patient will survive. If we don't have this time, we should buy it. And we should buy it by good, proper training. And I see it. And also, I was great fan because I work in the medical facility, training facility. So I'm huge fan of standardized training. But you have to remember that sometimes you cannot put standardized training in the non-standard environment. And it's very difficult. So in NATO, we started to talk in 2020 about improvised medicine, about how to deal with patients in terms of lack of medical capabilities, logistics. We call it class 8, which is the logistic medications and equipment. Because from time to time, we are so focus on the new technology, on the AI, drones, and the future of the warfare, that we forgot. We forgot about the crucial medical capabilities and knowledge, which is two hands and the brain from time to time. And we should be not dependent on that, because if we are so dependent on the ultrasound and you just imagine lack of power supply. We are no longer in the situation that we can do the fast protocol or put the patient into ventilator and ventilate patients within 72 hours because of the lack of energy. And we know that energy right now is and power supplies is weaponized by the enemies. So as you can see, there is a lot of challenges, but still, I'm 100% sure that the proper training and the exercises, both in the in the military and civilian facilities, and the integration of both civilian and military facilities, is the recipe for the success.
Yeah. So something you just mentioned there, Anita, is around CCPs, so casualty clearing points. And what I really want to touch on here is really around referral pathways and indeed triage, because like you said, there's maybe quite a lot of disparity between different NATO countries in the standardization of trauma pathways and indeed how patients will move through that move through the CCP, the casualty clearing station, to indeed get to that surgical intervention. Could I get you to speak to, and something we're realizing now actually as well, Anita, is actually those priority one patients almost don't need to be held at a CCP, because if they're absolutely multi-system trauma and they need, to your point, blood, they actually don't need to be held at all. If you have air superiority, great, utilize that. If not, land assets just to try and get them to some kind of surgical definitive care, and or blood on the way. But could I get you to speak to really the standardization really of trauma pathways within NATO, and indeed how that started to align to contemporary medicine?
So in Afghanistan, it was easy because the volume of casualty was low. So as I said, we were in this pink bubble that we have more medical assets than the casualties. So one of my friends, surgeon, said a very wise sentence that in Afghanistan, in that time, trauma patients has had more chance to survive than within a rural area in Poland because of that quick time of evacuation. So we can be very good with the as you said, triage, and the triage right now is based on the priorities, and we know that the priority one is always with the surgical capabilities, to be evacuated to the surgical capabilities. But what if we don't have this time? Should we? And I know this is very controversial, and but I should say that because it's worth to mention. We need to discuss very sensitive topic, which is the reverse triage, in terms of lack of quick evacuation or evacuation whatsoever. We should think about that, because if we spend in high intensity conflict a lot of time for the patients who are no longer the case within 72 hours, what about our resources? I know it's very controversial, I would say, but we need to bring that up in the discussion, and we discussed it. But it's very difficult because NATO is a value-based alliance, and for example, there is also nation point of view. The point of view for the eastern flank would be a little bit different from the Eastern Europe and even the US, because the medical assets are differ. So, and in Afghanistan, it was so easy. I know that I'm opportunistic right now, but it was easy because we have experienced surgeon, we had experienced paramedic, we have mixed groups, air evacuation, and we have 4 or 5 patients. So at the end, we have good TCCC guidelines. I should underline this as well because we did a great job in terms of TCCC guidelines and the TCCC development in among the NATO. It's a standard right now, golden standard, and we are good in the position that we had this first step in terms of TCCC. Now we need the second step, which is the PCC, prolonged casualty care, damage control resuscitation. Use the technology, use drones, use in on the battlefield, evacuation. We are struggling in also with the drone evacuations, for example, on unmanned platforms because of the lack of assessment during the evacuation. We don't know that the patient cannot be assessed properly when there are no crew on board. And what if tourniquet was loosened? What about the patient condition deterioration? A lot of consideration. As I said, we are facing a lot of challenges right now.
So let's talk about communication, Anita, and just how you aligned communication back in the Afghanistan war amongst NATO countries, but also communication going forward, because you already articulated it there, saying, the label, a Polish label is maybe hard to differentiate for US soldiers. But could I get to speak to just the wider concept of communication, radio comms, and indeed how handover protocols, standardization of handover. Could I get to speak to sort of the wider concept of communication across NATO countries?
So actually, it was easy because of the standardization. So we have a MIS protocol for handover. We had a nine-liner in terms of medevac request. And of course, with the trauma teams, mixed trauma teams, we train. We train and we train how to communicate in the closed loop, and we train how to do it in a proper manner and in a proper way. We had the same, basically, NATO protocols are the same. So, and the medical English is maybe not easy, but but we have forms, NATO forms for handover, for trauma team form. So we had all the necessary information that we can fulfill. But I would say that in terms of multinational cooperation, always training is the first step.
Yeah, absolutely, absolutely. I think to receive that common ground and that common understanding, absolutely. So could I just get you to speak to really just the lessons learned, Anita, from coordination and indeed integration that informed later multinational operations? Was there any post-conflict debrief which really sort of improved coordination and integration?
Oh yeah, definitely. We started from the equipment. We try to be as interoperable as we can. So we are based on the TCCC guidelines equipment, and also when it's my personal point of view, but we try to um, build a medical scenario in each exercises based on the lesson learned. Not to forget about that, because in this very advanced multi-domain exercises, from time to time we forgot about that. We are forgot that we will have casualties in these operations. So we brought I said Alliance bring that up and try to exercise as much as we can. We checked. So we from time to time we are build our medical capabilities in a modular way. So there is some input from one country, for example, the roll one and the medevac assets are from a hosted nation, for example. So that why we in that way we can cooperate. So standardization, I would say that standardization in terms of training, proper training, in terms of equipment, I would not say the scope of practice. However, NATO issued the minimal treatment requirements, which is good, and we are always looking for that. Because, for example, in Poland, paramedic is a academic educated individual practitioner. In the US, paramedic is a course-based education. So and the scope of practice is different. But when we put the minimal treatment requirement, NATO is sure, and the alliance is sure that this is the minimal that we can do to save the patients. If you can do more, do it. It's good for you. Do it. But if you cannot, you should fulfill at least the minimal treatment requirement. And the medical treatment, minimal treatment requirement is always about the golden hour and the quick evacuation.
Yeah, indeed, absolutely. And to your point, I think it's really good to war game and battle test when you don't have power, when you think certain things are removed from you, because I think to your point, it's understanding what suboptimal what's points of weakness and single points of failure, and just trying to remove those so you can still deliver a bundle of care irrespective of, like you said, the ultrasound machine and or different point of care devices, so that actually there is no you're trying to remove some of those single point failures from the system, which is absolutely key. Just looking, Anita, and pivoting slightly, and looking at outcomes and challenges from the Afghanistan war, but also just coming forward, were there any trauma systems within NATO which had sort of the biggest influence on patient survival and morbidity, and in a way were maybe adopted more wholesalely by NATO?
I would say that the NATO doctrine is it's a good example how to build a proper guidelines for the NATO nations to fulfill all the necessity brackets to have the survivability on the proper way. Now I think that we taking into consideration that at the beginning of the Afghani war, the TCCC was just the beginning. It's a quite new standards, and we see how it's grown. So I hope that the PCC and different kind of high tech technology, drones, whatever, will be the game changer in the future battlefield. But also, on the other hand, we should not forget about the basics and not to be very strict and also dependent on the high technology. So that would be my point of view. And TCCC was a great success, and the research showed that the survivability was higher. It was high, and the tourniquets, and they were great game changer on the battlefield. Tourniquets, but we see tourniquet right now. It's a still game changer, but we need to do it in a proper way. And once again, evacuation time is crucial. You can put the tourniquets on, but what if you have patients within 72 hours? You have to deal with that. So, and you see that there was also the challenges. It's the medicine is like a wheel. So I don't know whether you know it, but there are some cases right now in Ukraine of gas gangrene due to the delayed tourniquets and the conditions on the trenches and the conditions on the battlefield. So can you imagine in Afghanistan that we will say, yeah, we should deal with the gas gangrene. it wasn't the case. So, and you see, it's like a wheel, and we see that the wheel of medicine is crawling a little bit, but I'm sure that NATO countries and are value based, and they face the challenges, um, and we succeed. We will. Yeah, we gonna succeed on that part of the modern warfare.
Yeah, listen, indeed, and to your point, Anita, and you make it's a profound point. It's the wholesale adoption of TCCC and everything that comes from that with March. Just looking also at the prolonged casualty care, this which is really interesting because the wholesale adoption of March and the prolonged casualty care is fundamental, so that you're all speaking the same medical language. But so just as we pivot slightly, could you get to speak to kind of any best practices which, despite the systemic differences, they converged, NATO has converged on? One of the fundamental things you just bring up there is about converting a tourniquet and just knowing how to convert a tourniquet and when is appropriate to convert a tourniquet to potentially avoid limb loss if there is hemorrhage control without the use of a tourniquet. Could I get you to speak to sort of that mindset shift of being able to teach tourniquet conversion and other practices which start to salvage limb and life more appropriately in the evolving battlefield?
Yeah, so definitely the tourniquets, it's a great example. And also in terms of Afghanistan, I would say that the airway management started from the simple needle NPA, and then through a surgical, I don't know whether you know, but CLS level US medic can deliver the crike, surgical crike. And for us, at the beginning of the Afghani war, it was like unbelievable to have maybe in our Polish way of thinking, non-medical personnel to deliver that advanced procedures. Also the needle D. However, so it was, I think, those March protocols interventions was, I think, the game changer on the battlefield. Even the March protocol was, I think, the Nobel Prize worth. Simple protocol for everybody, from the point of injury for the soldier itself to the body aid and to the role two. Everybody using that simple protocol to assist patients. So I would argue that those March protocols and the crucial intervention was a game changer. What we need, more advanced protocols, TXA, blood far forward, surgical capabilities, uh, pain management, antibiotics, fasciotomy, in terms of massive burns. Sorry. So these are the protocols for delayed evacuation designed for the PCC. And for me, as I said, 10 years ago, 15 years ago, when I imagine myself in the situation that CLS, non-medical personnel, will deliver crike on somebody, it was mind-blowing. And now we are thinking about the fasciotomy. Come on. But I think we are heading in that direction, that combat medics, paramedics, non-medical personnel could be trained to do those medical procedures. Also, when I'm seeing that, I'm not talking only that you will be responsible for the diagnosis, for the decision making, and everything. I'm talking about that when you train sorry, not patients, that would be great. But when we train medical teams, combat medics, and the non-medical personnel in that manner, and we are I'm saying the medical assets are overwhelmed by the volume of patients, he can also assist you or deliver some medical procedures on just to gain time for the patients. I would say this is the extended golden hour.
Listen, I think it's profound, and to your point about training, the shift there is, like you say, wholesale adoption of TCCC, March, and the prolonged casualty care, but also to your point, training non-medical soldiers in medical interventions, and it's a baseline. And it may be just intramuscular injections of TXA and pain management and good wound care, how to convert to how to apply a tourniquet, how to convert a tourniquet, but bringing these interventions forward, closing the gap, closing the time on this type of care, like you said, is an absolute differential for survivability. I get, in a way, my last question, Anita, as we come into close on the podcast would be, and we've touched on many different concepts really in the conversation, but my final question really would be around if you could redesign a multinational trauma collaboration in conflict zones, Anita, what are some of the key principles you would prioritize?
I would say that muscle memory standardized training at the lowest level of care, not to put some details, physiological, pathophysiological details, just a muscle memory, standardized training. The exercises for delayed evacuation as much as we can in the multinational environment. Bulk evacuation, so evacuation of thousands of soldiers via different strategic evacuation. And at each point of medical evacuation, I would say damage control resuscitation, damage control surgery, trainings as much as we can. We can integration of civilian and military assets. So don't forget about that because we need to do it. But exercises. That's my last point on that.
Yeah, listen, that's fantastic. And to your point, Anita, around training civilians and not underestimating the utility and advantage of training if civilians in some of these medical practices because they are ready and willing and quite to your point, sometimes often the first on scene in these incidents. Listen, thank you for the last 45 minutes. It's fantastic to get your thoughts and indeed reflections both on some of the empirical research you've done, Anita, and indeed your contemporary practice. So thank you so much.
For having me.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.